again, in a lot of meetings that we start, especially when we're doing presentations, I like to make sure that we have that out there so folks can see it, because these are the way in which we like to conduct business, and that our community can count on us to move forward with them in a great way. So when we look at our strategic pillars, we put everything everything we look at trying to move forward, we should be looking at from these pillars in terms of is it good for the organization, which pillar does it fall under, and so that we can track and monitor any initiative that we're trying to implement or that we have implemented to make sure that it meets the needs of the community and meets the strategic priorities of the organization. I just want to quickly talk about what's going on around the system and some of the current and future initiatives for Samaritan. The Samaritan Medical Group, it was formed about a year and a half ago. That they've come together under their own charter. We've taken all of the clinicians, doctors, nurse practitioners, PAs, physician assistants, nurse practitioners, CRNAs, and put them within this group. And before they used to report up through the hospitals, now they report up through the medical group and partner with the hospitals, trying to create a culture around the medical group, and then also creating the strategy around what clinicians does each community need or each service line needs, so that we're not competing by site, but we're actually coordinating a strategic plan around the delivery of healthcare with our providers. So that group has been up and running for about a year and a half, and they've come together really nicely and still moving forward in a positive way for the group and for the system. And with the medical group and with the hospitals, we're looking to increase patient access. When we look at all of the feedback from our communities, we keep hearing across the board that they have to wait longer to get in to see our providers, and so we're trying to increase access. And I think one of the areas that will help us around access is going to be telemedicine. I think that telemedicine was not necessarily the outcome we would have liked to have seen from COVID, but it was an unintended consequence of COVID, in that when we shut down our clinics for a little while, telemedicine had to step up and rise up, and so telemedicine is becoming a bigger part of our ability to access our patients and our patients to access us. Work in diversity, equity, and inclusion. There's a lot of things that have happened throughout the year that has shined a light on this. I'll report out that over a year ago, January of 19, we put together Samaritan, a group around diversity, equity, and inclusion. They were stood up almost 2 years ago. There was a list of work and things that they were trying to get put together. So we had the group set up, and then as we look through what happened in 2020, we've been leaning on them more and more, and they're starting to create a direction and long-term planning and strategy around enhancing diversity, equity, and inclusion. Manager summits, Doug Boyson has had manager summits all year. They were small groups based on COVID. We weren't able to meet as a large manager group. There's about 250 managers across the system. We used to meet 4 times a year over at Boulder Falls to talk about what was going on around the system. And over this last year, we had smaller groups of about 35 that met and talked about their thoughts around Samaritan and what was going on in their particular area. And they were from all 5 hospitals and all 5 of our sites. So putting those groups together, we got great feedback, and we were able to get out a lot of the messaging around what was happening with the system and then what was happening at each site. So that was a very useful tool. And moving forward, we're going to continue with those summits. Focused on sustainability and operational efficiencies. We've actually been in a good position over the last 3 years. We've been looking at where can we gain efficiencies. We've had Huron come in, take a look at the hospital, all the hospitals. We've had Optum looking at our clinics. We had other folks, another consultant looking at the hotel. We've now got GE taking a look at OR efficiencies. And so as we look across the system, we really have started to focus on. We've built a lot of really great infrastructure and a lot of great programs. We now just have to operationalize those and make sure that the efficiencies are built in. So that good work is going on, and we've been made aware of and implemented a lot of operational efficiencies around the system. Again, expansion of primary care. We're still looking to make sure each community has the right number of clinicians to provide services in each one of our communities. One of the things around expanding primary care, if we look at, one would say we don't have enough buildings. We're running out of space for primary care in all of our communities. And in some of our communities, that's right. We just don't have enough space, and we do need to create greater space. But the other thing we have to start looking at too is we expand primary care, and some of our clinics have already done this. It's expanding hours Monday through Friday. 8 to 5 is the work day for most of us. But as we look at the provision of care and our patients and customers that need that care, 8 to 5 might not be the most practical time for them to receive it because they're at work. So trying to get open earlier in the day, open later in the day, and potentially open on weekends. I think that, again, utilizing those spaces more hours of the day in some of our communities, and in some of our communities, we're just going to need to build more clinic space for them. And then we hired Dr. Margaret Makula, our Chief Quality Officer, and she's going to be directing a lot of the work around safety and high reliability organization. And really all we want to do is start to move towards, we always wanted to create zero harm in our organization. And again, what she will always say is that if zero isn't the number, then which one of us or our family members are we going to sacrifice or allow harm to? And I think we would all say that we would not want to see harm to our family, ourselves, or to our patients. So zero harm is the goal. How do we get there? That's a journey we're going to have to work through, and then we have to start measuring the appropriate things. And as we start to measure those, we might know an outcome. We want to reduce mortality. If we want to reduce mortality in the hospital, we've got to figure out what is driving our mortality. Is it pneumonia? Is it heart attacks? Is it strokes? We've got to identify where the biggest risk is to mortality in our hospitals, unplanned mortality, unplanned death, unexpected death, and then start to drive positive outcomes in those areas. So as we look at safety and high reliability, we're just at the trailhead there. Margaret Makula, Dr. Makula, is going to be driving that for this system. So as we look to quality, I hope everyone is aware. If not, we are a 4-star hospital. When we look at the CMS star ratings, it's out of 5 stars. I think most of us are familiar with 5-star ratings when we look at hotels, restaurants, and other service-oriented providers. When we look at the hospital, our goal by the end of 2021 is to be a 5-star hospital. We received a 4-star rating this year, so the team here in Lebanon has been working very hard, again, around quality and patient experience to make sure that we are on the path to get to 5-star, and we are right now maintaining our 4-star rating and hope to achieve a 5-star rating by year end. One other area that of note is that dealt with the guidelines, stroke Silver Plus with a target. We were recognized there for our commitment to providing the most appropriate stroke treatment according to national recognized guidelines. So again, another opportunity for us to let you all know that our staff is working hard to meet the national guidelines and benchmarks so that we can provide exceptional care in our hospital, and we do. When we look at another program that we started up this year was the STARS program, Samaritan Treatment and Rehabilitation Services. We finally opened up our residential treatment facility, and that opened up in August. That was a great undertaking. That started about 3 years ago. We were just going to build it. We bought the property, and we were ready to go. the system, the healthcare delivery system across the state. Well, the legislature hit us with a tax. That tax equated to millions of dollars a year on Samaritan for Albany and Corvallis, and so it was not prudent for us to start 3 years ago the building. We then went off in a full-fledged orthopedic, our philosophical campaign to raise those dollars. And very quickly we went from $675,000 to over $4 million in a philanthropic campaign, and we were able to get the funding, get the building built, and based on, unfortunately, on COVID, instead of opening in April, it opened in August. We're treating both men and women 18 years of age and older, and we've had roughly 6 to 8 inpatient patients at any one time. Again, with COVID, we're trying to be cognizant of the fact that we don't want to put 2 people in a room, so we're utilizing single rooms right now, but we are treating people with substance use disorder in an inpatient setting now, which is very positive for the system and our communities. We have 7 new clinicians that joined the team over the last year. You can see each one of them. Dr. Bruner's over in our family medicine resident clinic. That's where she came up through, knew about Lebanon through being in that clinic and wanted to come back and work there, so we're lucky to have her. Dr. Bruns, geriatric medicine. We have a program that outpatient program that we work in the VA, we work at Avamere, and we're going to start to pick up other assisted living facilities throughout Benton County and Lynn County and Albany and Corvallis to start to take care of patients that are in those facilities. What ends up happening right now, just as a general practice, they have a primary care doc, usually one of our primary care docs that works in a clinic. They're busy Monday through Friday in their clinic, seeing anywhere from 18 to 25 patients. A facility would fax the clinic with requests for orders or maybe to see the patient. They would, in a lot of cases, wrap the patient up, put them in a transport, whether it's ambulance or non-ambulance transport, to the clinic to be seen. What Dr. Bruns does with the geriatric medicine group is they go right to the facility. They take care of those patients there. They walk around. They're walking around them almost daily. So they might not be scheduled to see someone, but they can definitely put eyes on them to make sure that they're okay. And if something does come up, they're right there in the facility to take care of them. So we're lucky to have Dr. Bruns, again, fellowship-trained geriatric medicine. So she's great to be leading that program. Dr. Christensen joined the hospice program, so he's a great addition to our hospice program. They're fully staffed right now. We got Nadia, certified nurse midwife, for starting a midwifery program here in Lebanon. We've recognized that we have our 3 OBGYNs. We're recognizing about 100 or a little over 100 births a year happening at the midwives in the community. And we still have some of our patients that would like to have a midwife experience and maybe have with a backup of a doctor or a medical type of environment. And so having Nadia here, we're marketing her, and we'll start to offer those midwifery services to patients that are desirous of that type of encounter. We got David over at Urgent Care, who joined us in the walk-in clinic, and we also have Joshua that's in the health center providing primary care. So we've got a nice group of folks. And then Rachel, our RNFA, so First Assist, she joined our program as well. Our surgeons need someone who knows how to hand them instruments and work as their First Assist. So she was hired on the program to work with our surgeons in the OR. From a sustainability perspective, we take a look at the financial snapshot. When we look at COVID and the fact that who would have thought that we would have had a pandemic that would have shut healthcare down or brought healthcare to its knees, and this pandemic did that. We shut down the hospitals, we shut down elective cases back in March, and if you look at our the snapshot from our financials for Lebanon, year to date, we're sitting at operating income, net income of a little over $8 million, almost $8.2 million on a budget of about $5.5 million, or a positive variance of $2.7 million. So our hospital and clinics have done a fabulous job. One of the things that's helped us with this bottom line this year is that Lebanon is a critical access hospital, and as a critical access hospital, mainly what that is a reimbursement model, so that little hospitals in small communities were going to be sustainable. So it's a reimbursement model. Part of an additional reimbursement model is rural health clinic status, and that gives an enhanced reimbursement for clinic visits in our outpatient clinics based on the fact that we're rurally designated. And so we've got an enhanced reimbursement for our clinic visits there. You add all that up, and the fact that our clinicians have been very busy, working very hard. The folks in the hospital have been working really hard, and the team here have managed expenses really well. It's put us in a very positive light year to date. Again, almost $3 million favorable to our budget in a very, very complex and difficult year. Some of the partnerships with the Lebanon Community Hospital Foundation, you can see some of the things. Here's just some of the list of things that they've helped fund for the year for the hospital and or the clinics. It's again, as the hospital is being the sole member of the foundation and our trustees have worked very hard to fundraise for us, and then in return use those dollars to help support the operations of the hospital. I won't go through the entire list. As you look at that list, though, again, if our community and employees didn't give to our foundation, these would be expenses that as hospital operations we would have to fund, which would take dollars away from the other things that the hospital funds. So the partnership with the foundation and the community, and the fact that people donate to our programs, our employees donate to us, these are just some of the things that our foundation has been able to support our hospital this last year, and making sure that we're able to meet the mission of taking care of our patients and building healthier communities together. So we look at the growth in telehealth. I've talked a little bit about that. Again, we started out at the onset of the pandemic. It was a complex issue that needed to be addressed, and we've talked about it for many years. And we did not have a platform to start telehealth. So we used this platform that we're on today, which is Teams. And so Teams was never really set up for health delivery, but it was the platform we had. And so again, it's the platform we used, and we're getting better at it. And we're actually getting hopefully a new platform to be able to better support our providers and our patients in the quest for telehealth. It offers 3 options. You can go through MyChart, eVisit, there's a video visit, and there's telephone visit. So we've really stepped up our ability to meet our patients where they are, try to avoid any interactions in a clinic if they're vulnerable and don't need to be in a clinic. So again, telehealth is something where we went from less than 5% televisits in February and March pre-COVID, and those were basically stroke-type visits in the emergency room and limited psychiatric visits. So there was not much telehealth going on, and I'll tell you, by August, over 75% of our visits were being done on telemedicine. So again, we stepped it up, moved it up quickly. Our patients and our providers very quickly adapted to telehealth and telemedicine.
Hey, Marty.
So, yes.
Just sorry, on that last slide, we had a question. If you wanted to answer that, Dave was wondering about the difference between a MyChart eVisit and the video visit.
Sure. Just generally speaking, when we look at the MyChart eVisit, if you're signed up on MyChart with your provider, you could log into MyChart, ask some questions on MyChart. They would review your chart and then get back to you through MyChart. The video visit would actually be a scheduled time visit where we would set you up on a Teams meeting like this and interact with you if you have the technology to do it. And that technology would be either the computer or the phone, the smartphone, or if we couldn't get that video visit set up, we would then move it to a telephone visit so that you could better explain and interact with your provider. So a MyChart eVisit again, is more I believe, just an interaction through MyChart and not necessarily speaking face-to-face with your provider. So hopefully I addressed that for you. So our COVID response, if you remember back to March, the VA was the first hotspot in the state, and that was middle of March. It was probably March 10th, March 12th. I forget the exact date. The VA had the first COVID positive patients, and then a very big spike. They had over 30 patients over there at one point that were testing positive for COVID. So it was the first hotspot in the state. We had the OHA, Oregon Health Authority, staging in our conference rooms to get over there to help the VA with PPE, personal protective equipment, with masks and gloves, gowns. The VA didn't have a lot of that. A lot of us didn't have the volumes of PPE that we do today. And so we were a staging site for the VA. We had shut down our hospital in elective cases right when that happened. We were about 5 days ahead of the governor's order. And that's not that we were infinitely more, had more wisdom than the governor. It's just that we had the first hotspot and needed to shut down and secure our hospitals. So we did that a few days before the governor's order back in March. We've worked closely with Lynn County Public Health on PPE and all the things that we needed to do around COVID and COVID awareness. There's surge plans in place now. We've talked, we meet every week now on surge planning to make sure we understand the census of where each hospital census is, where their staffing is, which hospitals are on divert that are not taking patients. And it's important because what we're seeing right now, more so than not, is that we're not having bed capacity issues. Each of the hospitals generally have the beds to put a patient in. The unfortunate part is we don't always have the staff to staff those beds, and a lot of times it's not COVID related. If you think about families with kids at home from school, or kids not being able to go to daycare based on an exposure, we're really kind of stuck around staffing models right now, and not so much bed capacity. So around surge planning, some of the things that we're talking about in that arena is sending less acute patients to lower acuity hospitals. And what I mean by that is if you don't need to be at the Regional Medical Center in Corvallis, would you be better off being in the hospital in Lebanon, maybe Newport, maybe Lincoln City, so that we can keep the Regional Medical Center open for trauma, our cardiac cases and things of that nature, that the Regional Medical Center is the only place that our community can get those services done. So we're looking at how do we potentially send less acute patients to the lower acuity hospitals. That's just one of the topics we talk about. The other thing we might be talking about, that we do talk about in our surge planning, is alternative care sites. And again, our issue is not beds today, but what could happen as cases continue to climb is folks that leave their assisted living facility, whether it's COVID related or not, are having a hard time or almost impossible to get back into their facility right now because they're closed to anyone coming back in based on potential issues around COVID in their community. And so one thing that could start to impede our ability to take care of patients is if we have patients in our hospital that no longer need to be in the hospital, that have nowhere else to go because they can't get back into their facility. And so we're continuously talking about alternative care sites to see if we needed one. And one that's a possibility is we have the Boulder Falls Inn, our hotel is now closed. I mean, people aren't traveling, and there's no meetings, there's no events, and so we've closed the hotel for the next probably 6 to 8 weeks. So if we needed an alternative care site, the hotel might be a spot to go to. But as we go back to my prior statement, we're not having bed capacity. It's staffing concerns. And if we're having staffing concerns in the hospital, how could we staff an alternative care site? But we've got to be considering all these areas and making sure that we have contingency plans. And I think part of the contingency plans would be working with these assisted living facilities to see if they can help us staff. Because again, people are not going to need a lot of medical care; they're just going to need the assisted living care. So again, around search planning, we've got a lot going on around that right now to ensure that we can maintain elective cases, elective surgeries, and make sure that we can get people in the hospital if they're sick and need to be in an inpatient status. And we have a COVID hotline that was set up back in March, and basically they were there to answer questions for the community, and still are, and they're also there to contact people who come in for a test for COVID, and we were contacting everyone. Now we're just contacting positives. So again, there's a hotline there to help with questions in the community and to contact people who've been tested. And if COVID wasn't enough, we had wildfires in the state, unprecedented wildfires, and I'll say that the community rose up in support of Lincoln County. Here's a picture of myself, Katie McLean, our HR director, in the middle there, Ryan Combs, and we've got Taylor on the right, and we've got Derek on the left there from Good Sam Foundations, and we've got a truck full of goods that we drove out to Lincoln County in support of our staff out there who lost everything or who were driven from their homes because of smoke. So again, we joined up with the community and took one of our trucks over there with a lot of supplies for our employees. When we take a look at community partnerships, each of our communities, each of the counties were given $150,000 in social accountability grants to offer our communities. In the last couple of years, Lebanon joined with Albany so we could look at this from a county perspective, because what ended up happening is that a lot of these services go from Albany out to the East County and back. And so some of these folks were asking both the hospitals and maybe and we wanted to coordinate what we were doing and how we were doing it. And so when we look at the grants over the last couple of years, we've come together as the two hospitals to serve the county. And here are the grants that were awarded this year. They add up to about $132,000. We had an ask of over $400,000. And I will say the good work done by the committee members was that, again, we recognized there was great need in the community, but it had to meet up with the 4 pillars that I showed you earlier, and to make sure that that fell into one of those buckets, and that also met the needs assessment that each one of the communities does. And as we looked at all of the ask, the committee recognized that there's great need in the community. But when we took that, when we added up all of what they suggested for each one of the asks, it came up to $132,000. Then the thought was we could have, dispersed the other $18,000 to all of these great organizations, or maybe we should hold on to that $18,000 because there's going to be an unexpected need that's going to pop up in the next year. And so we as a committee decided that we would hold on to that $18,000 for an unexpected need that we know will be coming up in the next year. So a lot of good work done with our community partners and all the good work that they do. And here's the foundation long-range planning. So this just is a slide of the direction they're going, and I think what the overall message here is that we need the foundation is creating for each one of our communities a 3 to 5 year strategic plan and what the priorities are in each of our communities, and start to put that out there so that Brandy and each one of the foundation directors has something to talk about when they're out there talking to our community. And then not that they're lacking for things to talk about, but when we start looking at philanthropic campaigns, we had one, and that was the STARS program. That was our full and total focus across the valley especially in Lebanon. And I think as we move forward, if we could have 2 or 3 or 4 different initiatives that Brandy is talking about as we're going out and talking to the public and talking to potential donors, and we want to make sure that what we're looking at from a hospital perspective, the foundation is ready to support from a strategic perspective, and that they're able to have those initiatives to make sure that our donors are fully aware of all the services that and initiatives we're trying to implement over the next 3 to 5 years. And again, we're not going to be successful if, without the foundation. So the foundation partnering with the hospitals and working on our strategic plan, working on their strategic plan, will give them the strategic initiatives to talk about when they're meeting with the donors in the community, to share the direction and the needs so we can all get there together. We start looking at, again, working with our community partners. We recognize that fire, EMS, and law enforcement have been overwhelmed over the last year. They always answer our call whenever we have issues within the hospital, from people becoming unruly and becoming violent in the hospital, and also on the community. Their response to all of the community, the disaster on the fire, COVID, transporting our patients from hospital to hospital. We just needed to recognize that we wouldn't be successful without them either. So what we did is go out and get some donations around food and other things. And as you can see, there's a picture of just buckets of food and toys and other things that we sent to each one of the fire department, to EMS, and to law enforcement, both for the sheriff and the local Lebanon Fire Department. So we just wanted to make sure that we were recognizing those partners and all of the hard work they're doing and the devastation that they've had to work through as well. The employee engagement, the one area that I'm really impressed with, year over year at Lebanon, and I was at Lincoln City as well, is our employees contributing and participating in the employee caring campaign every year. And especially this year with all of the things that have gone on around COVID and around the wildfires. If you look, our goal was $135,000. We hit that goal. 50% overall giving. I think that almost doubles what other hospitals in the system were able to get from their staff. And 76% participation. Significant participation. I'll maybe explain to you the difference between the giving and the participation. We have ambassadors that work with Brandy that go out and talk to our staff. Those ambassadors have jobs that are important to our organization, and what we ask them to do is stop that work for a period of time, an hour here, an hour there, go out and meet with people in their department or their area, and talk to those employees. Those employees have a job that's very important to the organization. What we ask them to do is stop what they're doing, hear the story of the foundation, hear what's happening within the foundation, what all of the areas that there's opportunity that the foundation is meeting, and then ask them if they'd be willing to donate. And as you can see, 57% of our employees gave. The one other thing that we ask them to do, if they don't have the ability or the desire to want to give to our foundation, what I do ask them to do is sign their card. And signing that card, what that tells me and what it tells Brandy is that our ambassador did their job. They went out and told the story. It also tells me that the employees stopped, listened to that story, and signed a card. And it's important to me because everyone has an important job and an important role, but I also think that the foundation and the foundation support of the hospital and our campaign every year, if people stop for a couple of minutes and hear the story, I think they want to be part of something. And when they understand exactly what it is that the foundation does, overwhelmingly they want to be a part of it. And so when we can meet our goal of $135,000 this year during COVID and wildfires, have 57% of our employees give and 76% of our employees participate by signing their card. I'm thoroughly impressed with what Brandy and the ambassadors do, and I think our employees are phenomenal, and I greatly appreciate the good work done by everyone. You can read the the anonymous quote at the bottom of this yourselves. But again, there's a lot of really good work being done and a lot of things that are meeting the needs of both our community and our hospital. So if you look at the emergency fund now, we set up at Samaritan emergency fund for our employees that were impacted by the fire. It was and COVID. So there's a lot of things that we needed to support our staff around. You can see that it was funded by the Lebanon Community Hospital Foundation. 35 Samaritan Lebanon Community Hospital staff supported since March. Help with bill such as rent, insurance, the utilities, PTO donations. Again, you can go all the way down there. You can see help provide child care. So again, for almost $50,000 in investment support awarded to these staff members. And again, a lot of the dollars that went into this emergency fund is our employees donating to this fund, so that our employees are helping their fellow employees. So again, a lot of good work that goes into fundraising around this. And again, Brandy and her team do a magnificent job of taking a look at those needs, looking at them in a blinded type of way and making sure that we're meeting the needs of our employees, so that, again, we don't lose them and that they're supported. And then some fun stuff. We have a hospital week. We get folks, we have them doing all sorts of arts and crafts, walking around, thanking them for the good work that they do. We give them treats and feed them some meals, and just have a good time and thanking our staff. We would not be in a positive position today without all these good people doing the good work that they do and spending some time appreciating them. There's never enough time to do it, and a month isn't nearly enough, but we do have a fun time during the month supporting and appreciating our staff. There's a science slide here, and I'm not going to even try to do it justice, more so than to say that vaccines are now in application for emergency use from Pfizer and Moderna. The vaccines, mRNA vaccines, I'm not going to try to explain the slide, but they work. They're being again pushed through as emergency use. Samaritan has been asked to be a staging site for the vaccine, and potentially a hub for the Pfizer vaccine. And the reason just for the Pfizer vaccine is that it needs to be stored at -70 degrees. So very, very cold. We bought a freezer to do it. So we're more than likely going to be we'll be a staging site for our employees, but we'll also potentially be a hub for our 3-county region. And if you do look at this slide in phase 1, there'll be a short period, but there won't be a lot of, doses will be limited, trying to get this out to healthcare providers and such, high-risk folks. You got the emergency rooms, urgent cares, frontline nursing staff within our hospitals. There's a prioritization list as to who goes first, second, third, and you can see in this chart there'll be a larger number of doses out in phase 2, and then phase 3 we should a routine strategy around how we get vaccines out. Probably much like the flu vaccine, we'll have an annual process around it. But again, Samaritan is a staging site, and we're about to finalize becoming a hub for the region. So it'll be good for us, in that we'll be staging vaccines for our region, so we shouldn't have to wait to get it from anywhere else other than from the state or from the government. So, and then what's in store for 2021? Hopefully we've addressed COVID, and we're back on track to again focusing on our strategic pillars and core competencies, expanding primary care, and just getting back to business as usual. And that is my presentation. Any questions, comments? Feel free to open your mics. We can have a conversation, or type in the chat if you like.
Marty, how were you able to hold down expenses so much during the year?
Yeah, good question. The expense management was both one around labor, and during the first few months when we weren't doing elective cases, again, it was folks working less hours. I mean, that was the unfortunate part, is some of our staff were home on absence. They just weren't working their full FTE. And then the other piece around it too was some of our most expensive supplies, again, are around surgery and some of the services that we weren't providing for about a month and a half or 2 months. So again, as we weren't doing surgeries, we didn't have the need to buy a large number of supplies around that. And then just pure expense management. Each of our managers did a magnificent job of trying to stay with a just-in-time supply methodology, to not buy everything for a year, but start to buy things from a quarterly perspective or monthly perspective. And the staff did a magnificent job of managing each one of their areas. And again, as we enforced and continue to thank them for, is if we look at it globally, it seems a Herculean task, but if each department does their little bit, all those little bits really do turn into a significant savings for the organization. So our managers are to be commended for the good work that they did in managing and managing the supplies they had, and also managing the purchasing of future supplies when we knew that there wasn't any disruption to those supplies. We didn't need to hoard those. So a lot of good work done.
Marty, I see a question in the chat about clinician burnout. If you have concerns about that, if you want to address that question.
Yeah, clinician burnout that's always a concern for us. I think around the over the last year in the beginning, I think that my concern more so around burnout then was trying to transition these clinicians to a platform, a telemedicine platform, and the areas that we're concerning is clinicians thrive on that interaction with their patients and talking with them and seeing them, and I can tell you that created more angst for the clinicians, was that they didn't have that touch, that interaction personally and in person with their patients. And so that was a bigger concern earlier in the year, as we've transitioned back to most of our clinicians seeing all of our clinicians seeing most of their patients in person now. The high-risk patients that are more vulnerable might be on a telemedicine platform, but burnout's a concern. We're always watching out for that. Again, I think that they've responded positively to what's been going on. If you talk about being in medicine, it's a once-in-a-lifetime event, and I think some folks have thrived around the idea and what's going on. And I think that they're doing better now that they're seeing their patients in person, but it's definitely a concern. And SMG, that's part of the reason SMG, Samaritan Medical Group, we're formulating that, is getting that clinician group as a group, so that they can build that culture around support of each other, and making sure that it's not that we didn't do a good job as each site, but having that group managed by the doctors and managed by the clinicians and looking at the clinicians has really been helpful in identifying people that are having a hard time, and make sure that we get the appropriate support to them. Alrighty, maybe one last chance or offer for questions, comments.
Marty, I was wondering if you could advance that last slide as well. I just wanted to alert our participants that we do have some continuing med talks this week with our Albany and Corvallis CEOs, and also in the chat I posted about a webinar next week with Dr. Brady if people are interested in more information about the vaccine. So those are opportunities. And I see some questions in the chat here for you, Marty. Mary was asking a little more information about the CARES federal money. Was that for the whole system or specifically for a hospital?
Yeah, great question. No, the CARES Act came in, those dollars came in and identified for each hospital. So it came in for each hospital. And so the idea, the legislation came out and said, here's dollars, distribute them to hospitals. Each hospital, and as a system, we got CARES dollars in. And then they started to write the rules around how we could book those CARES dollars as a hospital and then as a system. And so the fact that Lebanon did really well last year, and the methodologies of booking those dollars were either lost revenue based off of last year's performance, or lost revenue or decreased revenue based off our budget this year. And last year was a phenomenal year, so that wasn't the best methodology for us to choose. And then as we look at where we stand today, about $2.7 million favorable to Lebanon's budget. There's not many CARES Act dollars that Lebanon is able to book today, but as a system, we can look at all 5 hospitals, and if any hospital is missing on one of those methodologies, we can book those CARES dollars to that hospital. The good news is Lebanon has performed well, and we have not needed or had the ability to book a lot of CARES Act dollars as a system. It's helped support some of our other hospitals that had the opportunity to actually get some of those dollars on their books. I think we've booked about 3/5 of the dollars that we were offered in the CARES Act we've been able to put on the books, about $30 million, and there's about $20 million that we have not been able to put on our bottom line yet, but we have till June of next year to do that. So again, the CARES Act dollars are for each of the hospitals, and then as a system, we can address all of those dollars as a system or by site, whichever way is favorable for us to actually put them on, get those dollars into our bottom line and support our lost revenue.
And as a follow-up question to that, Marty, Mark was asking if you're aware of any legislation that's being introduced that may suggest any additional financial support in 21.
You know, I don't know that we're going to see any more financial support coming out that I know of. The state came out with some dollars for critical access hospitals in 20 as well. And so I think right now with the vaccines that are coming out and how it looks, and it's predicted that, you know, hopefully by the end of the second quarter into the third quarter, we'll get to that 70% vaccinated herd immunity type of perspective. And so I am not aware of any dollars that are going to come back to the hospital. You know, I think they're looking at another stimulus package for the individuals, but I do not know of any other dollars, and actually don't think there will be any other dollars coming to hospitals or such in 21.
I don't see any more questions, Marty. If you have anything to conclude with, and I just want to thank all of our participants again for joining us today at the Lebanon Hospital Foundation and Marty. And if you want any more information about how to join any of those upcoming Med Talks, feel free to reach out to me. So have a great day, everyone. And thank you so much, Marty.